Good afternoon, everyone. Our presentation, there we go. Our presentation's a little bit different. Being the shy, quiet, introverted type that I am, rather than talk to a PowerPoint, we thought we'd just have a few pictures of some of the things that happened during the project, workshop, and our online program that we developed. We also decided that we would be a little bit different in our presentation, and rather than talking about the objectives, the outcomes and all of that sort of thing, we would actually present the project, the good, the bad and the ugly. Trish is helping with the good and the bad, and the project team decided that I'd be the ugly and just present the project itself. One of the things that we discovered right through is that the participants in our projects just continued to be so generous with their time, in their knowledge sharing, and just helped us so much. We had a project meeting yesterday with the registrar, and during the discussions he started talking about, he was talking to Dr. So-and-so the other day, and I'm thinking, where did this doctor come into? One of the senior physicians in town suddenly became involved on a voluntary basis on the project. So it was just, we're overwhelmed by the support. As our clinical placement was about to commence in the aged care facility, we found that the education modules was becoming a fairly important basis for the orientation and the continued support for the registrars and the students. We started off with a workshop, and some of the pictures up there. It was designed and it was presented in a way to actually challenge the participants' attitudes and their personal beliefs. Some of the questions that we asked were something way outside their comfort zone, and we made them think about it. It was well regarded, and it's now becoming an annual event. In order to broaden the educational module side of things, we decided to convert it to an online course. As it was unplanned, there were a couple of delays in actually getting it up online. But certainly so far the initial feedback is that the workshop and the online education has been a success, and it has furthered the confidence levels of the participants. One of the things that we looked at was asking some questions in our control group, the before and after, of things like, does completion of the 6 online education modules in aged care by GP registrars increase their confidence in managing aged patients? Does the placement of a registrar in supported and supervised clinical attachment to a residential aged care facility increase registrar confidence? Is the routine scheduled session of a doctor in a residential aged care facility financially viable? Like it or not, it does come down to dollars. We also started to look at, does a regular scheduled visit with the doctor actually improve the resident's health, both physically and mentally? Yes, it comes down to dollars, but at the end of the day, we are here for the patient, for the resident. Does a regular scheduled session with a doctor in an aged care facility actually decrease hospital admissions? And does it reduce the amount of call-outs to GPs? One of the questions and one of the comments often by GPs and aged care facilities is, when do we call the doctor? Why do we call it? Do we call the doctor? Do we call the paramedics? Do we get them to come up? So we were looking at that. That was what the whole concept of the project was all about. In order to look at some of those questions as an educational tool, it was necessary to obtain ethics approval, and I would have to say it was one of the most in-depth and quickest ethics approvals that flew over the course of 3 or 4 days over a weekend of drafts back and forth. We monitored the clinical placement, and we followed the benefits, such as the relationship building and the community and the familiarity that was developed. We looked at potential recommendations. We also looked at the good, the bad and the ugly side of it. The participating practice, we used a practice to supply our registrar. The participating practice actually has seen the benefit and the value of the clinical placement, and they're now going to actually continue on with it after the project finishes. It's a bit early in the process and we need to do a few more in-depth studies, but at this stage it's proving to be financially viable for a registrar. As we got further into it and we got towards the end, one of the further add-ons to the project that we discovered after talking with our registrar was, whilst as a registrar he was certainly competent and knew what he was doing, he just needed a couple of thought starters on exactly where to start as he arrived with a resident that was losing weight, for example. We came up with the concept of instead of him ringing his support supervisor or the geriatrician, we came up with the idea of developing some short 3 to 5 minute videos that he could tap on through a mobile phone app, go onto it and basically have a specialist or a GP talking, saying, you know, in this particular instance, have you thought of this? You need to look at this. Start doing these few tests and look at that. We haven't loaded them up yet. They're in production, but certainly the feedback initially at this stage is everyone's waiting with bated breath. Despite all of the various unexpected changes that happened throughout the project, we saw the outcomes of the clinical placement actually enhanced the original project. It happened because of great people that were involved in the project. It also happened because of the generous volunteered time by doctors, by specialists, by organisations such as CSQTC, the University of Queensland Rural Clinical School, Queensland Health, or Department of Health as they're now known, supplying access to their specialists and they're at no charge. And it was just that total collaboration that made the project go a lot further and a lot quicker than we could even imagine right at the beginning. I'll hand over to Trish, Dr. Trish, who's going to talk a little bit about the actual clinical placement.
Thank you very much, Ken. So we very much base this intervention education on GP registrars who are in their first year of clinical placement in general practice. So, so they were sort of registrars who have only had in their first 6 or months of general practice. And we did it 2 ways, one with the workshop, which then went on to 6 online modules that they could then do in their own time, and they get education hours to that. But I guess, and for that we got the ethics approval. More interesting was actually changing the model in which GPs actually do general practice within our community. And so we actually chose a GP registrar who had no interest in aged care. He had actually just come from a paediatric placement prior to starting general practice. So he wasn't an enthusiastic registrar. But he was willing to actually go to an aged care facility for 1 session a week and actually take responsibility for the patients that the practice involved were actually cared for. And he actually went out with an aged care practice liaison nurse that, although there's no Medicare funding, this practice actually created this position because they saw the importance of that. we spoke to the registrar yesterday, and he said that if he had his time over again, he'd be putting up his hand because he found it an extremely valuable educational experience. Things that he found were really important was that it actually increased his confidence in dealing with patients within an aged care facility, but also with aged care patients that he sees within the community. That it gave him more knowledge surrounding the Medicare item numbers, because it does come down to dollars when you're running a business. He became more aware of the specialist help that was available, both the geriatricians, the site geri unit, and just even some of the physicians in town who were very willing to actually assist him in caring for his elderly patients. And I guess it also helped prevent some of unnecessary hospital admissions because he was there on a regular basis. Some of the things that have come from this study, and I think is where we're going to be taking it, we hope, next year, are actually, I guess, the vital role that comes between the relationship between the GP and the residential care facility has, and that where problems arise are more often than not because that relationship has broken down and the communication has broken down. We've also seen the value of actually having an aged care a GP practice liaison nurse, and we would like to sort of look into that further. And from an overall side of things, and actually having aged care workshops, the online modules, and actually having this placement, that it increases GP's confidence, or GP registrar's confidence in dealing with the elderly population. And because of that, these online modules, the workshops, we will be continuing, and interesting, the GP practice is actually going to be continuing on this model quite voluntarily next year, which is all very exciting. So, thank you.
Thank you.